Okay, hi everybody. I know folks are still coming down, but I'd appreciate it if we can just get started. And folks in the back, please encourage folks to come down towards the front. Thank you for being here. Thank you for presenting. I'm Mary Rojas, Medical Student Research Day Director. Let me pull up my slides. All of you are working towards this. So either if you're a first-year student, you're working towards looking for mentors and projects. If you're a second-year student, you will likely have presented your work today or will be presenting in subsequent years. Our Medical Student Research Day is not just year 2 medical students presenting. Sometimes we have year 1, scholarly year, 3rd years, 4th year presentations, I'm being told. There you go. I want to highlight this here, the scan. If you haven't looked at our abstract book, the abstract book lists all of the abstracts, also indexes for the various types of topics, mentors, and student directories. So please take a look. It will be posted on the Icahn website in the next few days. So let me just summarize the vast scope of the work that all of you have done and year after year do. So literally A to V, not A to W, but A to V. You're doing scholarly activity in all of these different areas, which is pretty impressive. Some schools will offer specific projects or data sets that you can do work. What's really nice that I've been very impressed with all the work that you're doing, and I'm sure everybody else has, a lot of the facilitators were, wow, students were great. Because you're doing it in a whole range of topics and you're working with faculty all throughout Sinai and beyond Sinai, which is really quite impressive. I'm sure it's very nerve-wracking, but I'm sure you've seen that it's definitely worth it. So I do want to thank people who were made today possible, obviously yourselves, but I just wanted to name a few folks. So here are the track advisors. Many of you will recall these individuals, read your abstracts, gave you feedback. Their main role was to focus your project into something that was deliverable within this time frame. As you know, research takes many years to do. And so instead of trying to expect that you're going to do a 5-year project, which is unrealistic, they narrow it down to maybe one research question or a subset of a multi-center or multi-time wave study. So thank you for the track advisors. I apologize, I'm not going to name everybody because there's too many names. On this slide are the mentors who mentored the platform presentations, as well as the posters. And so I just wanted to sort of shout everyone out. It's been pretty impressive, like I said, the numbers. So we've had over 100 presentations, and that's an awful lot. So you should be proud. And these are all of you. So these are the names of the oral presenters, as well as the folks who gave the poster presentations earlier. So not everyone who's here, or we do have people viewing through Zoom, may realize that this is the second portion of our day. We've just had poster presentations that were pretty amazing. People were able to Zoom in. I bounced in and out to see them. I think they're very impressive. I jumped into a few sessions. I think it's pretty impressive. And your facilitators told me that you guys have done a really good job. So you should be very impressed. And I'm impressed. You should be very proud. Poster facilitators. So unlike other poster sessions where you might be in a room with, 50 aisles of 50 different posters that are printed, we decided a few years ago to do digital presentations, 1, to save you money, but 2, to sort of move up a little bit. It also allows us to have people Zoom into presentations who might otherwise not have been able to come to see your presentation. That could be your co-authors, it could be faculty, it could be family, it could be anybody you would have wanted to, including here. Hello. So your facilitators facilitated the individual sessions. This year we had a total of 16 sessions, so thank you. And funding, always important. Anyone who does research knows you're always asking for money. Many of you received funding for the summer, and from a range of areas, COSLOI, CMCA, DIH, MSTAR funding, Rock Health, TISH, the US Senate, which is pretty impressive. Foundations, societies, and a lot of these are summer funding, which means you submitted applications to these programs and you were selected. So it doesn't go unnoticed, and I just want to share this up here. Also, the individuals who help coordinate over 100 medical students' stipends for the summer, Jackie and Darinka. And then finally, I want to thank the MSRO committee, myself, obviously, Jenny Lynn, Keith Siegel, Yakira is floating, running around somewhere, and Grace. They've worked really hard to sort of set this up. It takes many months to sort of set up today. The abstract book designers, because we really feel like those little touches mean a lot to you. So we want to thank Melissa and Stephanie. And then the volunteers who helped organize, move things around today, Daniel, Leora, Jahira, Lauren, and Hyro. So I just want to thank everybody, and I want to take a moment for all of us to just applaud each other and recognize all of your efforts. Thank you. So I get to say thank you. So I want to introduce our next welcoming speaker, Dr. Charney. He is the Anne and Earl Erkrantz Dean to the Icahn School of Medicine at Mount Sinai, President for Academic Affairs at the Mount Sinai Health System. Please welcome him.
Well, first I want to add my congratulations to all of you. I went through the abstract book, and there is some amazing, work there. You're to be congratulated. I want to add my thanks to the mentors and the leadership of the student research programs. This work is incredibly important. Whether or not, you decide to become a researcher, as a major part of your career, some of you will and some of you won't. But no matter what, having a research experience is important for your career because once you become a physician, it's a learning process throughout your career. You're going to be reading articles in the New England Journal, in Lancet, in JAMA, your specialty journals, and you're going to need to know how to understand what the research is all about, whether it has clinical implications for your practice. And that the research experience that you have in medical school will help you do that. And then some of you are going to spend most of your career doing research, thinking bold, coming up with bold ideas, pushing the envelope, and some of you are going to make discoveries that save lives. And this is the beginning of that process as well. So I hope you've valued the experience that you've had. The school is going to put more money into medical research for our medical students so that nobody does not get a research experience because of finances, because we view the research that our medical students can do as extremely important to your learning and ultimately your career. So congratulations on great work. I look forward to the presentations. And keep it up. Thank you.
Hi, everyone. Jenny Lynn. I get the pleasure of being able to introduce the speakers. So our first speaker is Juan Sebastian Arroyave, and he is going to be presenting work he did with Ari Hakimi, doing a project on renal recovery and clinical outcomes after surgery for a renal mass in a solitary kidney. So let me just pull that up.
All right, hello everyone. My name is Sebastian Arroyave. Today I'll be presenting my project from the summer I did at Memorial Sloan Kettering, titled Renal Recovery and Clinical Outcomes After Surgery for a Mass in a Solitary Kidney. So to start us off, a little background on renal cell carcinoma. Worldwide, there's about 400,000 new cases per year and about more than 170,000 deaths per year. In the United States, there's about 82,000 new cases per year and 15,000 deaths per year. It's about 2 times more likely in men than in women, and the median age of diagnosis is about 64 years old. Some data from the National Cancer Institute. Most disease presents in a localized state in about 65% of patients. And unfortunately, in about 16% of patients, it presents metastatically. The big thing with renal cell carcinoma is that there's no screening done normally for this type of cancer. And so a lot of these masses are discovered incidentally. Some established risk factors for this cancer are smoking, hypertension, as well as obesity. Some background on the management as well. The European Association of Urology recommends partial nephrectomy as the standard surgical approach for small renal masses, those specifically under 4 centimeters. This indication changes drastically in the setting of advanced disease, given that the idea wouldn't just be to resect the tumor, but to also treat the metastases. The background is different when you have the case of a patient who only has 1 kidney, because if the disease is more advanced, the tumor has more endophytic characteristics, is not as easily resectable, you have to take out the whole kidney. And some of these patients will end up with a single kidney and then get cancer in the other one. So that is a situation where you have what is titled a solitary kidney. And so partial nephrectomy in this case still remains the gold standard for treating masses in this specific clinical scenario, given that the idea is that you want to treat the patient's cancer, but at the same time, you want to preserve as much renal function so that they stay off hemodialysis. So that is the big challenge with treating renal masses in a solitary kidney. It's finding that balance between preserving enough renal parenchyma as well as finding the best oncological outcomes for the patient. Thus, our research questions were 3. What patient characteristics, perioperative factors, and surgical approaches are predictive of postoperative renal function recovery? Specifically looking at both clinical as well as oncologic outcomes. Second question was, what are the risk factors for postoperative dialysis? Again, looking at both clinical and oncologic outcomes. And third, what does the survival look like for these patients at MSK specifically over the last 20 years? So our methods, we used our retrospectively maintained database that included patients from 1989 to 2019, and we included all patients over the age of 18 who received a partial nephrectomy and a solitary kidney. We included their demographics such as age, sex, BMI, smoking status, hypertension, hyperlipidemia, diabetes mellitus, ASA status, EGFR as well. In terms of oncologic variables, we included the laterality of the tumor, nephrometry scores, which basically is this combination factor that takes into account a bunch of tumor characteristics as well as the size of the mass and sort of the geographic positioning of the mass within the kidney. TNM staging, grade, as well as resection margins, and perioperative factors included the partial nephrectomy duration, estimated blood loss, the length of stay, the approach, the ischemia type, as well as the time. So to start us off with some of the results, here are the demographics of our cohort. We included 145 patients. As you can see, even though this captured patients from 89 up to 2019, there was only about 145 cases. It's a very rare clinical scenario. The median age for our patients was 62. Most of them were male, and most of them were former smokers as well, given the big risk factor we talked about as well. In terms of surgical and oncologic characteristics, I'd like to highlight that most of these cases were open. Again, this is in trying to preserve as much renal function as possible. An open approach gives you the ability to really resect very carefully and preserve as much renal parenchyma as possible. So I want to elaborate on this concept of ischemia time, given that the kidney is such a vascular organ receiving about 25% of the cardiac output. You have to clamp the hilum in some of the cases in order to get a good resection that doesn't lead to a lot of blood being lost during the procedure. So the ischemia time is a big concept in terms of what partial nephrectomy is, because it's been associated with, like, longer ischemia times tend to lead to worse outcomes. But what's been established is that trying to keep the time under 25 minutes is the ideal. So that was a good thing that we found in our cohort, is that the median ischemia time was about 25 minutes. Tumor sizing was about 3 centimeters median. Most patients had a PT1, PT2 stage, so early disease, and renal nephrometry score was 8. So this is what I was talking about in terms of ischemia time, is where you clamp the hilum while you try to resect the mass. Another one of our results here was looking at renal function recovery post-op. So to highlight a few things here initially, the red line indicates the average renal function preoperatively, which was 55. The scale that we're looking at here is eGFR. And what we saw is that 1 week post-op, on average, renal function declined to 36. This is expected because what you're doing when you operate on these kidneys is you're causing an acute kidney injury during the procedure. So you'd see that immediate decline in renal function. We followed it in the time points that you can see in this graph. And what we saw is that we got a really good recovery in these patients, going back up to 48, which is only about 7 points below what we saw pre-op in these patients, establishing partial nephrectomy in the renal mass in a solitary kidney clinical setting as a safe procedure for these patients. As I said, one of the things that we looked at is what are the factors that are associated with postoperative renal function, looking at both clinical and oncologic characteristics. For this analysis, we couldn't do a multivariate regression analysis, which would be the gold standard to try to isolate the effects of different variables on eGFR. So what we did is that we subdivided our cohort into smaller groups to try to isolate within each of those groups the effect of different variables on eGFR. So first we look at our full cohort, which was made up of, again, 145 patients. And we looked at the associations of these variables you see here on the y-axis with postoperative renal function. What we saw is that an open approach was positively correlated with better postoperative renal function. Age was negatively correlated with worse renal function post-op, and a better baseline renal function correlated with better renal function post-op. Important things that we found here. Then we looked at a subgroup of ischemia time. Again, to reiterate, not all patients get their renal hilum clamped during a partial nephrectomy. Some, given at the surgeon's discrepancy, they don't clamp the renal hilum. I guess it's in the setting where the mass is more exophytic, and you'd see that like there's no need to clamp the hilum. And what we saw is that there were other factors associated with ischemia time, as you can see here. Then when we looked at our open cohort, we saw that estimated blood loss correlated negatively with post-op renal function. We also looked at the minimally invasive cohort, and the only thing that we saw correlated with better postoperative renal function was a better baseline renal function. Another thing that we wanted to look at is what are the factors that are associated with ending up on dialysis post-op. About 6.7% of our patients ended up on dialysis post-op, and only 4.1% ended up on dialysis permanently. And so one of the factors that I want to highlight here specifically is that masses that were in the T3 stage, so more complex renal tumors, associated with a higher need of dialysis post-op. This is a Kaplan-Meier curve for survival of these patients over the 22 years that we looked at. And the overall survival for these patients was really good at a median of 11 years post-op, establishing, again, this approach for RMSK as a very good for oncological control. And then finally, we also looked at cumulative incidence causes of death following following RMSK surgery. And what we saw is that at all time points, at the 5-year, 10-year, and 15-year mark, kidney cancer still dominates as the primary cause of death for these patients, reiterating the fact that oncological control is of extreme importance while balancing it with good renal function. So finally, a few conclusions here. The thing with renal mass in a solitary kidney is, again, finding the right balance between getting good oncological control for the patient, as well as trying to preserve enough renal function to keep them off hemodialysis. Sorry. And trying to find that balance is pretty hard. So this is part of that process that we're trying to establish what are things that we could use to better inform our approach for these patients, as well as improve the clinical decision-making in these specific scenarios. I'd like to thank the team that made this possible, as well as my mentor, Dr. Hakimi. And lastly, I also want to dedicate this presentation to my father, my mentor, a great physician who died from renal cancer 2 years ago, and this is just very meaningful to me. Thank you.
Hi, at this point, we'll see if anyone has any questions. We'll bring the microphone over to you. Yakira's over there on that side. Yes, 1 second.
Great presentation and great work. Regarding the improvement of kidney function post-surgically, it seems like there's a lot of overlap in the range of outcomes. So could you talk a little bit about why you think that this average is an accurate representation of the improvement after surgery?
That's a great question. I think one thing that the team talked about after creating this graph and trying to map out what average renal function looks like post-op, we came to the conclusion that a better way to probably map this out, given that there's just so much variability between like baseline eGFRs for these patients, and that most of these patients actually with this mean of 55, they had CKD stage 3 before even going to surgery. A better way to probably represent how their renal function is changing postoperatively would be to look at percent change from baseline instead of raw eGFR numbers. So yeah, no, I really appreciate you pointing that out.
Hey, Sebastian. I thought that this was really awesome, great work, and thanks for sharing it with us. I thought you did a really creative job of kind of parsing out groups to account for the fact that you said you couldn't conduct a multivariate, which was like a creative solution to that. I'm curious if you could elaborate on what was the barrier to that, or also is there any kind of discussion on other factors you want to specifically target maybe for a future project, if that's of any interest? But thanks again.
Yeah, thank you, Mike. I'll just explain this again because it was confusing to me when it came up. The linear regressions that we didn't do the multivariate analysis because there was collinearity between the outcomes that we were trying to use to predict eGFR. The way someone in stats explained it to me was like, if you're trying to predict the sweetness of a cake using the amount of flour or the amount of sugar you're adding to the cake, and if you're adding the same amount of sugar and the same amount of flour, how are you going to predict this, if which of those two is adding more to the sweetness of the cake? So because there was that same amount of rate adding to the batter or whatever. So, but back to your question as well. Given that we found this obstacle, we're trying to reframe our data in a way that instead of just looking at the full cohort and trying to divide it into these different surgical approach subgroups and whatnot, a better way to probably look at this would be to focus on what is termed a high-risk partial nephrectomy, even in the contralateral kidney setting. That would be something where you have a tumor with a high nephrometry score, which indicates that it's probably large, it's invading into the renal vein, it's endophytic, more complicated surgically. A tumor that's more T3, so more advanced, and also tumors that are generally larger. So using those three things to group our cohort into what would be high-risk partial nephrectomy versus a lower-risk partial nephrectomy would probably help us deal with some of this collinearity that we're looking at.
Thank you. I think we'll go to the next presenter. Thank you so much. And great job.
So our next speaker is Annie Chang, who is going to be talking about work that she did with her mentors, Nicholas Gulati, who's right here, and Emma Gutman. She's going to be talking about transcriptomic profiling of the immune and inflammatory signature of sclerotic type chronic graft versus host disease tape strips. Come on up.
Hi everyone, my name is Annie Chang, and today I'll be presenting my project, Transcriptomic Profiling of the Immune and Inflammatory Signature of Sclerotic Type Chronic Graft versus Host Disease Tape Strips. As some background for this disease, graft versus host disease, or GVHD, is a life-threatening complication that can occur after allogeneic hematopoietic stem cell transplant, which means after someone has received a transplant from a donor. And typically, GVHD arises when the transplanted or donor cells regard the host as foreign and attack the host. And damage to the host occurs as a result of a systemic inflammatory reaction induced by T lymphocytes present in the graft. There are two types of GVHD: acute, which typically occurs days after a transplant and affects multiple organs such as the skin, GI tract, and liver, and chronic GVHD, which usually occurs after 3 months of a transplant and can affect a lifetime. And most frequently, chronic GVHD affects the skin and mucosal membranes. Around 10% of patients with chronic GVHD develop sclerotic type chronic GVHD, or SCGVHD, which is characterized by inflammation and fibrosis of the dermis, subcutaneous tissue, or fascia, and can have diverse clinical manifestations as seen on the right. SCGVHD confers significant disability and morbidity and affects patients' quality of life and day-to-day living. However, there is currently not a single satisfactory treatment for this disease. Current first-line treatment includes topical corticosteroids, immunosuppressants, calcium urine inhibitors, phototherapy, but these treatments are often associated with adverse effects, and there is no consensus on steroid-refractory GVHD. Therefore, there remains a significant unmet need for safe and effective treatment for this disease. Patients with SCGVHD can have different clinical presentations. Some patients develop localized thickened hyperpigmented plaques on the thigh and forearm, which resemble localized scleroderma. Some patients also have shiny indurated skin on their torso, which can limit chest wall expansion. Subcutaneous fibrosis can also cause rippling of the skin and can cause joint contractures, such as the prayer sign here. And some long-standing complications of SCGVHD include poor wound healing and skin breakdown, which can increase the risk of systemic infection. The molecular phenotype of SCGVHD has previously been studied by using biopsies, which typically look at a deeper layer of the skin and are associated with pain, scarring, and infection. These biopsies are not very feasible in young children, and the pain, time, and inconvenience can discourage adults as well. In our study, we focused on a minimally invasive approach called tape stripping, which offers an approach to capture the upper layer of the skin, known as the stratum corneum, and can allow us to evaluate different skin conditions. Previously, we have used tape strips to study diseases such as atopic dermatitis and psoriasis. Tape strips are plastic tapes that have an adhesive side, and they can be sequentially applied onto the upper layer of the skin to capture more of the stratum corneum upon each time it's applied. So as an overview of how it works, the tape strip is typically applied on a skin and marked with a pen so the same area can be measured. Pressure is applied, and the tape strip is removed with a tweezer, and typically this procedure is repeated multiple times, around 15 to 20 times each. The tape strip is then placed in a vial and subsequently analyzed. So the aim of my project was to comprehensively define the molecular signature of sclerotic type chronic GVHD in pediatric and young adult patients. First, tape strips were collected from the lesional skin of 8 GVHD patients, and from the areas of normal skin in 9 healthy controls, and from the areas of lesional and non-lesional skin in atopic dermatitis in 11 atopic dermatitis patients. The GVHD and healthy controls were obtained from patients at Mount Sinai. The controls and AD were obtained from patients from Mount Sinai, and then the GVHD patients were obtained from our collaborators in Israel at Hadassah Medical Center. We used RNA sequencing to look at the RNA of the samples, and we conducted statistical analysis with an absolute fold change greater than 1.5 and false discovery rate less than 0.05. Those genes were considered differentially expressed. Here are the demographics of our cohort. As you can see, the 3 groups, control, SCGVHD, and AD, they were demographically matched, and there were no significant differences by age and sex. The average ages of the cohort were 13.1, 15.8, and 14.4 years, respectively, for the groups. And this reflects the pediatric and young adult population. And we focus on that because not much is known about this population compared to older adults. All the GVHD patients had a skin severity score of 2 or 3, which is classified as globally severe. So as an overview of the patients in our study, on the left, we can see a principal component analysis, which showed that there was distinct clustering between SCGVHD with controls in AD lesional and non-lesional. And of note, we did have around 25 control and AD patients initially and around 10 GVHD patients. And the PCA analysis allowed us to select which samples to include in our analysis. On the right, we see a Venn diagram looking at the differentially expressed genes between SCGVHD and the other diseases, and we found 5,634 differentially expressed genes between SCGVHD relative to control, where 5,345 were upregulated and 289 were downregulated. Next, we focus on the immune differentially expressed genes. So this is a heat map showing the relative gene expression across the diseases. The columns show normal, GVHD, AD lesional, and non-lesional, where a more red color indicates a greater degree of upregulation and a more blue color indicates a greater degree of downregulation. Each of the rows under the marker column correspond to a gene, and the subsequent columns, with the most relevant being GVHD versus normal, show full change comparisons between different sets of diseases. We found that several genes had related immune functions, such as those involved in T cell activation and proliferation, such as CD86 and CD2, genes that were involved in cytokines, such as IL-23A and IL-1F10, those involved in the MAPK pathway, such as S100A7 and MAP2K7, genes involved in the JAK-STAT pathway, such as STAT6 and JAK2, genes involved in fibrosis, such as S100A12 and IL-1RL2, and finally, genes involved in general inflammation, such as CD69 and TNF. To assess these changes on a pathway level, we conducted gene set variation analysis, or GSVA. And typically with GSVA, we can look at hundreds of pathways, such as keratinocytes, barrier genes, systemic sclerosis. But here we focus on the T helper pathways because they're the most relevant to disease pathogenesis. So on the left, we can see the GSVA for Th1, where the red bars represent the mean Z-score for each disease group. We found significant upregulation of SCGVHD relative to controls, and we also noticed activation of genes involved in systemic inflammation, such as TNF, OASL, and interferon gamma receptor 2. In contrast, for the T helper 2 pathway, we noticed minimal modulation of SCGVHD relative to controls. And of note, AD is a classically Th2-mediated disease, and we did not see the same broad activation in GVHD, but we did see modulation of markers such as CCL7 and CCL24. Finally, we looked at the Th17/22 pathway, and we saw moderate upregulation of SCGVHD relative to controls. As a reference, psoriasis has been known to be a Th17-mediated disease, and several blockers for IL-17 and IL-23 for psoriasis have been FDA approved and on the market. For this pathway, we noticed upregulation of genes such as CXCL1 and KRT1, which are genes involved in epidermal barrier function. So in conclusion, our findings show a distinct cutaneous molecular phenotype of SCGVHD using tape strips that align with previous studies that have used biopsies or focus on an older patient population. Specifically, we found strong Th1 skewing with JAK-STAT pathway activation and modest Th17/22 upregulation, which supports ongoing clinical efforts that use topical JAK inhibitors such as ruxolitinib to treat cutaneous GVHD, and also highlight the JAK-STAT pathway as a potential avenue for further therapeutic investigations. Limitations to our study include the small sample size, partly due to the rarity of this disease and the pediatric focus, as well as the predominantly male and white sample. In the future, we want to do transcriptomic profiling of other forms of GVHD, such as chronic lichenoid GVHD, to identify molecular targets for more effective treatment, which can be more promising compared to current first-line treatments, which are nonspecific and systemic. And as more targeted treatments are being developed for diseases such as atopic dermatitis and psoriasis, We hope that molecular profiling using the minimally invasive approach of tape strips can help us identify more targeted and personalized treatments for patients with GVHD. I'd like to thank my mentoring team, including Dr. Emma Gutman and Dr. Nicholas Galati, as well as the Tisch Cancer Institute for their funding and support. Thank you so much, and I'll take any questions.
Hey, Annie, thank you so much. This was a really great presentation. Just a quick question about the fold change cutoff. I was curious why you used 1.5 instead of 2, just in terms of like, is this just because it's an initial study, or was it a particular reason to include a wider population?
Yeah, that's a good question. I think initially, since this is the first time that we are applying this approach, we wanted to have, we want to initially use 1.5, and then as we add more patients, and as we continue the study, we might add more rigorous cutoffs for fold changes.
Thank you very much, Annie. That's a wonderful presentation.
Our next speaker is Joy Jiang from Dr. Girish Nadkarni's lab, who will be talking about multimodal fusion learning of diagnostic inherited arrhythmia syndromes using the electrocardiogram. Joy.
Alrighty. Hi, everyone. My name is Joy Jiang, and I'm a fourth-year MD PhD student in the lab of Dr. Girish Nadkarni, the Augmented Intelligence in Medicine and Science Lab. Thank you so much for listening to my presentation today. I'm excited to be taking you through one portion of my thesis titled Multimodal Fusion Learning for the Diagnosis of Inherited Arrhythmia Syndromes using the Electrocardiogram. Sudden cardiac arrest is the leading cause of cardiovascular death in the world. And in the United States, it causes over 1,000 patients in terms of episodes every single day. And if we were to examine genetic risk, in addition to environmental factors, we can appreciate the fact that if we were to examine genes with high frequency and low effect size, this underpins coronary artery disease, the most common substrate for sudden cardiac arrest. Meanwhile, alleles with low frequency but high effect sizes underlie inherited arrhythmia syndromes. And in today's talk, I'll be talking about one particular inherited arrhythmia syndrome, congenital long QT syndrome. Despite our advanced knowledge of the genetics underlying sudden cardiac arrest, there's actually a lack of scalable methods for genetic risk detection. And this is because universal genetic testing is hindered by requirements of expert interpretation, cost, as well as infrastructure. So the core question for my thesis is, can we infer genetic risk from more readily available modalities? One of the most common modality in medicine is the electrocardiogram, or the ECG. And the ECG is a device that provides information about cardiac electrical activity. And as shown in our lab, we can leverage the subtleties in waveform presentation to our advantage in order to predict and prognosticate a wide variety of different diseases. For my thesis work, I'm combining electrocardiogram as well as electronic health record data, EHR, to predict genetic risk of sudden cardiac arrest, specifically by integrating this data through a deep learning architecture. Deep learning is a type of artificial intelligence that seeks to mimic how the brain works in terms of processing data and recognizing patterns through the basic unit of a neuron. For today's study, I'm leveraging data from large-scale biobanks. Specifically, I'm using data from the Mount Sinai Biobank, as well as the United Kingdom Biobank, or UKBB as it'll be abbreviated. And these two biobanks were so selected because of their large inclusion of patients, but in addition, they represent disparate patient populations, whereas in the Biobank, we can see that the majority of participants are of non-European ancestry. Those in the UK Biobank are primarily of European ancestry. And so it will be leveraged in this model, the wide representation of different races and ethnicities, so that the model can apply broadly to patients of all different backgrounds. For this particular study, I am partnered with an assistant professor in the lab, Dr. Akil Vade, and this is our pipeline that we came up with. So first, we process electronic health record information through what's called a multi-layer perceptron, and this is a type of neural network in which all the neurons from one layer directly feed into the neurons of the next layer. And then for the electrocardiogram information, I'm using what's called a convolutional neural network to process the information. A convolutional neural network will use a convolution or a filter in order to extract the most important features and integrate that information for classification. And then I'm integrating the pieces of information from the EHR as well as the ECG into another multi-layer perceptron, and then trying to classify patients who could have high-risk genotypes for long QT syndrome. Just a little bit more background on long QT syndrome. It's a disease that affects 1 out of 2,000 patients, and it's so defined by prolongation of the QT interval. However, it's been seen that 40% of genotype positive patients present with a normal QT interval. But this does not take away from the fact that sudden cardiac arrest can occur in 13% of cases without any sort of warning. And models before in the past have been developed either on a mode of data, so to speak, so on either electrocardiogram or an electronic health record information, and only on patients of European ancestry. So the purpose of today's study is to try to combine ECG and EHR data and try to be able to apply this model on patients of all sorts of diverse racial and ethnic backgrounds. Insofar as methods go, we first collected pathogenic variants from the ClinVar genetic database. And then we decided to sample cases and controls in a 1:5 ratio. And this is so the model can recognize the presentation of genotype positive cases in contrast to genotype negative controls. And then we use a strategy called group stratified K-fold cross-validation to ensure the robustness of model training. These are the results now. So I want to show that the patients in UK Biobank and my Mount Sinai BioMe, they number 59 patients from UK Biobank and 16 patients from BioMe in terms of those who are genotype positive. We'll note that of the genotype positive patients, primarily those in the UK Biobank were of white self-reported race, whereas those in BioMe were entirely of non-white reported race. And we then measured model performance through the use of AU-ROC, area under the receiver operator curve, as well as AU-PRC, area under the precision recall curve. AU-ROC is a measure of how well the model can distinguish between two classes, and it is so scaled from 0.0, which is 0.5, which is just chance in this particular case, and 1, which is a perfect prediction. So here we have an AU-ROC of 0.76. Meanwhile, AU-PRC is a measure of how well the model can pick out positive samples, and in this particular case, the AU-ROC is 0.23, which shows an improvement over the baseline of 0.05. And then we further fine-tuned the model, further trained it on data from the BioMe Biobank, and we noticed that both AU-ROC and AU-PRC improved to 0.83 and 0.29 respectively. To identify the clinical utility of this algorithm, we decided to further look into the phenotypic presentations of the genotype positive patients in BioMe. We noted that 10 out of the 16 genotype positive patients had a normal QT interval on ECG, which indicates the difficulty of diagnosing this disease on ECG alone. And further, 1 out of 8 patients had an emergency presentation for syncope, presyncope, or ventricular arrhythmia, which underscores the importance of our algorithm in potentially helping to detect patients earlier on and facilitate better workup. We then decided to apply this algorithm to 11,446 patients selected at random from the Mount Sinai healthcare system, and our model was able to identify the top 10 patients with a high-risk genotype. And what we found was that among the 10 patients with the highest probability of disease identified by the model, 2 had ECGs and clinical histories that were suggestive of congenital long QT syndrome, as reviewed by a board-certified electrophysiologist. And for us, this highlights the fact that the model can help effectively and efficiently point out patients who are at high risk for long QT in comparison to a universal genetic screening strategy. So in conclusion, sudden cardiac arrest is one of the leading causes of cardiovascular death in the United States, and genetics plays a huge role in the risk of having such episodes. But using more common modalities such as EHR and ECG and integrating their data through a deep learning framework can help classify patients for earlier workup and for targeted intervention to prevent these sudden cardiac arrest episodes from happening. So thank you for your attention, and thank you so much, especially to my lab, especially those who are in the audience today. I also want to give a special thank you to my collaborators, as well as those in the medical scientist training program. You may have noticed the progress bar at the bottom of my slides, and this is the elevation map for the New York City Marathon. I want to see some hands. Has anyone ever run the New York City Marathon before or will run it in the future? All right, a couple people, awesome. And so I just wanted to point it out that New York City Marathon is one of the most challenging marathons because it has over 900 feet of elevation change. So if I could impart just one piece of advice to everyone here in terms of pursuing research in the future, I've learned that from competing in marathons and doing research, it's to really have to know your whys on those hills or any challenges that come your way. So surmounting those hills in this marathon of research becomes that much easier when you're able to dig into your why, and per the theme of today's presentation, run with your full heart. And last but not least, just a quick plug for the AI medicine workshop coming up. Myself, as well as the next presenter, Katie Link, will be helping to lead and organize this workshop, and we'd really love to share with you some more information about AI and how it could affect your future work as practicing clinicians, and we'd really love to have you. So the QR code's right there, and thank you very much.
Hi, thanks. This presentation was really cool and very interesting. I'm just curious about, you talk about the fact that this is a multimodal approach. Which data are you pulling from the EHR specifically to inform the model? And then what's the hypothesis behind why there is a signal in the EHR at all?
Yeah, so the EHR variables that we pulled included age, sex, as well as ECG-derived parameters, including QT interval, RR interval, and the like. And the reason why we are pulling these particular variables in general is just because we speculate that potentially long QT presentation could be affected by these specific clinical characteristics. So we decided to also provide them as input for the model.
A question over here. You got it?
That was a really, really interesting talk. Thank you so much, Joy. I was curious about the confidence intervals around your AUCs. I noticed that they were really tight, especially given that I think there were like around 50 patients or 50 observations from UKB. So I was wondering, were your unit of observations the patients or the EKGs themselves? Or another way of saying that was it one EKG per patient or multiple EKGs per patient?
Yeah, that's a great observation. So sometimes there were multiple ECGs per patient, but we sought to make sure that there's no overlap between the training, validation, and test folds by using group stratified K-fold. And the tight confidence intervals can be explained by the fact that we use something called 500 times bootstrapping to randomly select our patient population and run the model again. And that's how we're able to obtain this confidence interval.
Okay, thank you very much, Joy. Very informative. And please do scan that if you're interested. This is the first time we're doing this workshop, and it's basically being put together by medical students who have an awful lot of background. So please do scan. We will be sending that information out in another way.
All right, and for our last speaker of the afternoon, I'd like to welcome Katie Link, who will be talking about work she did with Dr. Eric Ehrman, longitudinal deep neural networks for assessing metastatic brain cancer on a large open benchmark. Katie, come on up.
Hello, everyone. First, I'd like to thank Dr. Rojas and the entire Medical Student Research Office team for this great event. Very excited to be here today. I'll be talking about longitudinal deep neural networks for assessing metastatic brain cancer on a large open benchmark. My name is Katie. My mentor was Dr. Eric Ehrman, who's been a mentor for me since he was a resident at Mount Sinai, is at NYU Langone Health. So to start off, I'd like to talk about an example case of metastatic melanoma. We have a 72-year-old man who's a second-generation fruit farmer in rural Wisconsin. He presents with an irregularly shaped 1.5 centimeter diameter mole on his right ring finger. Biopsy reveals melanoma. It's surgically removed, but he finds it difficult to attend regular appointments due to his work and his location. It ends up metastasizing 2 years later. He's treated with chemotherapy, but unfortunately on the last imaging, it reveals intracranial and lung mets. And unfortunately, he dies at home after 2 weeks of hospice care. And with some details removed, about 2 decades ago, this was the story of my grandfather. It was a really transformative experience for me, and really kind of inspired this work that I'm doing now on cancer dynamics, specifically metastatic cancer dynamics. And so we know that tracking real-world outcomes of patients with metastatic cancer is complex for a number of reasons. You have to track multiple lesions and secondary sites. There are also diverse treatment options, including medication, radiation, and surgery. And the scoring systems that we have to track these lesions are generally based on imaging, and they have limitations. They're time-consuming, and they rely on expert assessments, and so they're generally pretty expensive. So for an example, metastatic brain cancer, this occurs in up to 10% of cancer patients with a median survival of 6 to 18 months. Current scoring systems include RANO-BM and RECIST for brain, specifically metastatic brain cancer. And it's also generally hard to identify, measure, and track small metastases in particular. These are METs under 10 millimeters cubed. And so to address a lot of the problems that we have in looking at dynamics of medicines, particularly cancer, we can see that the data-centric AI movement might be an answer to this. So this really revolves around these large, diverse data sets that are needed generally to train performant deep learning models. These data sets generally are multimodal, including multiple types of data, including imaging, demographics, clinical notes, genomic data, and medications. And so with longitudinal data from these diverse data sets, the first-order dynamics could provide new biomarkers for understanding disease progression. It's also important that these data sets be openly available to promote robust science, but however, these can have logistical limitations. Open data sets accelerate research by others, they can improve algorithm generalizability, and they can also improve reproducibility. However, protected health information, PHI, must be appropriately safeguarded, and health data is generally considered commercially valuable, thus limiting the incentives to open data sets. So in terms of a research question for this project, we aim to answer, can we improve our understanding of metastatic brain cancer dynamics using a large data set and longitudinal deep learning? We had 2 research goals. 1, to build the world's largest single institution data set of brain cancer across multiple time points and with multiple data modalities. And 2, to use novel longitudinal deep neural networks to measure cancer dynamics automatically. So first, in terms of the data set creation and processing, we were aided by the Prospective Radiosurgery Clinical Registry at NYU, a screenshot shown here at the bottom. This lets us collect demographics data, clinical data, including medications, as well as helped us pull MRI studies easily, both from Gamma Knife as well as follow-ups. De-identification was a big part of this process as we wanted to open source this data set. So we utilized unique random IDs for patients and time points. We also used relative timestamps instead of absolute dates. And we also had an extra step during our MRI processing of skull stripping, as a lot of research nowadays has been able to show that you can re-identify patients from MRI scans, as shown on the bottom as well. So the result is that we created this large data set called the NYU Mets Brain Data Set. Quickly, by the numbers, this includes nearly 1,500 patients with a mean age of around 62 years old. It has 8,000 MRI studies, about 2,300 segmentations, 4,800 follow-up visits, and over 81,000 medical prescriptions. And this is an example of the MRI studies at the bottom. So now jumping back to our methods in terms of longitudinal deep neural networks, we had 2 steps in this process. We first utilized self-supervised learning, which utilized all the data, including unlabeled scans in our data set, to allow the general UNet architecture to learn some form of MRI data, how MRI data generally looks. The second step, we utilize supervised fine-tuning with our segmentation through time network. This utilizes the time dimension with convolutional long short-term memory blocks, LSTMs. We also tested conventional UNets here, as well as expert validated labels versus expert validated plus non-expert validated labels, as well as T1 sequence scans only versus T1 plus T2 scans. We utilize a number of metrics. Single time point metrics are standard here. Segmentation, we use dice similarity coefficient, as well as individual tumor volume. And we also did object detection, so precision, recall, and false positives per scan. And then we also created a number of longitudinal metrics, including the change in the number of tumors, change in total tumor volume, and change in individual tumor volume. And this, we heavily utilized algorithms to match tumors across scans, which we developed through our work here. The results of the longitudinal deep learning, the segmentation through time model, the STT model, had the highest dice score for metastases under 10 millimeters cubed, which, as I mentioned, has been a longstanding problem, specifically in detecting brain metastases. It also had the lowest mean absolute error for change in per tumor volume. However, the conventional UNet model had the highest median dice score over all tumor volumes. And we also found that this model generalized well to external brain met data sets, including Stanford's. And this is just a diagram of our AI-assisted cancer dynamics on one particular patient, showing how it is able to track individual tumors over time, over 4 time points here. So to discuss our limitations, one major limitation is the heterogeneity of this data set. We had a number of different treatments that were being done throughout the data set, so this could limit some of our understanding of cancer dynamics. The work that I have here did not utilize medication history, for example. And then also we have data processing errors and limitations. When doing a massive data processing pipeline like this, there's going to be errors that happen. A lot of these happen due to skull stripping, which was a major part of us wanting to make this publicly available and de-identified. In terms of future directions, obviously we want to improve these algorithms so that they can be more accurate. We hope to also expand to other sites of metastases, including the liver and the lung. And finally, we want to release the data set, code, and models to the scientific community so that to accelerate international research efforts. And part of this has already been done. So this is our website where we have released the data set. We've also contributed to the 2023 Brain Tumor Segmentation Challenge, which is the longest running medical AI challenge in the world and encompassed an international effort across this country as well as in Egypt. And we're also contributing the data and the code and the models to the Menai Python framework, which is an open source library for medical AI. So just to revisit the example case and think about a vision for the future with cancer care with AI. So we have the same 72-year-old man. He has melanoma. However, now his local oncologist is able to monitor his condition with AI's help. Meanwhile, research into cancer dynamics help discover new personalized treatment regimens for specific progression subtypes. And access to stereotactic radiosurgery is expanded with AI-assisted metastasis segmentation. Down the line, this patient's metastases are flagged by radiologists using AI on a follow-up MRI, and physicians assisted by AI treat the Mets with stereotactic radiosurgery and prescribe medication for his progression subtype. So I'd like to thank a number of collaborators. Work like this does not happen alone. My mentor, as well as a number of others within the lab, as well as AWS and NVIDIA for their support. I also received funding from NREF and RSNA through their medical student research grants, as well as through NYU Langone. And my mentor was also funded for this project through the National Cancer Institute. And another plug for the workshop, please join. Thank you all so much.
Questions? You've left me speechless. I'm sure you've left a lot of people speechless. So we'll just give it a second. Anyone else have any other questions? Okay, so please do join the workshop because I think there's a lot to develop. I hope today we did have a range of topic presentations. You see the potential of AI now for medical and for the future of medical care. So we are looking to develop a lot of this opportunities, particularly as Katie and Joy have expressed. There will be these workshops so you can learn more about exploring this in healthcare. Thank you so much. Thank you to all the presenters, to everybody here. Have a great day.
I'm going to keep you guys between now and dismissal, but I just wanted to once again thank everybody for all of their hard work in terms of putting together the research, your abstracts, your presentations. I really want to make sure we really give a huge shout out to your mentors, some of whom are here today, because of all the time and effort they spent in helping you develop and present your projects. And finally, we really need to make sure we thank Grace and Yakira in the Student Research Office for pulling this all together. But good luck, congratulations, you're done.